This week on the BackTable podcast.
I think the importance here is that this just brings to light some of the exhaustion that we have in our specialty in general, and now complicated by some of the current situation with COVID. It just sort of makes us think that we really need to take time for ourselves, take time for our friends and families, and really focus on yourself and taking care of yourself because that's important, and that's what will get you through life ultimately.
Ladies and gentlemen, welcome to the BackTable podcast. If you are a new listener, welcome. For our regular listeners, welcome back and thank you for listening. BackTable is a podcast committed to all things IR and endovascular. I'm Chris Beck and I'll be your host today. I'm a private practice interventional radiologist based out of New Orleans, Louisiana. Today we have a great episode lined up for you. Before we get to it, I'd like to take a moment to thank our sponsor, RadPad. RadPad was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RadPad radiation protection shields for all your fluoride-guided interventions. See radpad.com for more information, or you can contact them at info@radpad.com for a free radiation evaluation and no-brainer radiation protection cap. If you do get in touch with RadPad, let them know you heard about it from the BackTable podcast. With that out of the way, let's get started. I'm happy to introduce our two guests today. We have today Dr. Jeffrey Chick and Dr. Jake Bundy. Jacob, welcome to the show. Jeff, good to have you back on the show.
Thank you.
Yeah, thanks for having us.
Yes. Guys, if you don't know Jeff Chick, then you've probably missed out on a lot of our earlier episodes. You can see them at episodes like Advanced Intraoral Access, Endoscopy for the IR, and Complex Lymphatic Interventions. Guys, can we just take a minute to introduce both of you guys? Jake, we'll start with you.
Yeah, so I'm a R1 resident at Wake Forest University. I'm currently in track for their ESIR program, and I have worked with Dr. Chick on multiple research projects prior to this.
Excellent. And Dr. Chick, can you go ahead and introduce yourself? Tell us a little bit about the practice.
Absolutely. Well, I think first of all, Jake is underselling himself. He's done phenomenal things over the past few years and been an author on more than 50 papers, and he's definitely an up-and-coming star in IR, so look out for him. I'm Jeff. I'm now at the University of Washington in Seattle in an academic practice covering 3 different hospitals, predominantly spearheading the lymphatic and venous work, which I've discussed with you guys before. And thanks for having me again, like always.
Yeah, man, good to have you. So a lot of the topic today, we're going to be talking about physician burnout, a very important topic. And there was a paper that Dr. Bundy and Dr. Chick helped pen. And listeners, just so you know, we're going to provide a link for that article in the show notes. But let's just start out with the first basic question. Jeff, we'll start with you. What is burnout?
So we have 2 classifications or 2 things that we typically think of burnout. So the traditional answer is burnout is essentially any sort of emotional exhaustion that occurs in the workplace. And that's one definition that sort of focuses on the physician or the individual not being able to, the deficiency stemming from the physician or the individual. And then there's a second sort of school of thought called moral injury, which is sort of a mismatch between the individual and the environment that they're in. And due to sort of a malalignment of the environment that they're working in, the physician or individual can't cope with the external stressors. And that's sort of termed moral injury. So burnout and moral injury are these 2 sort of notions that go kind of hand in hand.
Okay. Jake, can I ask you, what inspired you guys to tackle this issue and put this paper together in the first place? Like, how did this all start?
I think a lot of this originated from me and Anthony, one of our co-authors as well. We were in med school at the time. We were kind of getting inundated with a lot of talks and meetings we had to go to regarding burnout, even among medical students. And we kind of took notice of this, and we started talking with Jeff and Ravi Srinivasa as well, kind of about this issue and seeing how much of an issue this has been around physicians. And basically from that, we realized this is an issue that hasn't necessarily been studied well among interventional radiology. And we wanted to kind of get a better sense of what the prevalence was within our specialty as a whole, and then kind of the factors that have been driving it for the individual physician as well.
Okay. So I read the article, and there were three things that were kind of mentioned in terms of describing burnout, which were depersonalization, emotional exhaustion, and lack of personal accomplishment. Jeff, can you kind of speak to each one of these, or maybe lay out some definitions for terms that are potentially going to come up in the rest of the podcast?
Of course. So this sort of all developed from some of the folks at Mayo Clinic and Stanford who study the health and well-being of individuals. And as Jake sort of alluded to, it's sort of become popularized over the past several years. So this all developed from a standardized survey, which has been formed to assess burnout. And as you alluded to, this survey assesses three particular things: emotional exhaustion, depersonalization, and overall personal achievement. And the emotional exhaustion component and the depersonalization components have scoring systems based on this 22-item survey, which psychologists and experts have used to score and determine individuals which are at risk for burnout or overall global exhaustion. The third component, the personal achievement, is just a factored in component, but it's not scored as a component specifically indicative of burnout.
The survey, so Jake, we went over to you. The survey, was it a survey that you guys put together, or was this a general survey that already existed that you guys were able to tailor to interventional radiology and then forward on to some of the IR docs around the country?
So the survey we actually used in the paper was a 34-question survey. 22 of those specific questions were consisting of the specific validated questions from the Maslow Burnout Inventory, which is that validated questionnaire that assesses those three axes of burnout. In addition to that, we also included 11 questions that regarded IR specific, including demographics, years in practice, practice environment, what level of training they were in, and how many hours they worked per week, as well as call responsibilities. So we tried to tailor it to IR as well as using the validated questionnaire.
Jacob, what were some of the findings that y'all came across with the results of the survey?
I think some of the more significant results that we found were when we looked at female interventional radiologists, we actually found 2.4 higher association of burnout among female interventional radiologists when compared to male interventional radiologists. And that was one of our major statistical findings. In addition to that, we also found that respondents who worked greater than 80 hours per week were at 7 times the risk of reporting the criteria associated with burnout compared to those who worked less than 80 hours a week. And I think out of our results, those were the two kind of core findings that brought this paper to prevalence. In addition to that, among all respondents of the survey, we also found a prevalence of burnout among interventional radiologists to be 72% as well.
72% of, and that's one of the findings that actually really stuck out to me, is that 72% of the respondents all reported, or I guess met criteria for some form of physician burnout. And I don't want to confuse correlation with causation, but is there anything that you guys were able to glean or knew on the front end going in that IR may stack so high as to the numbers of physicians suffering from physician burnout, or was this kind of a surprise in terms of getting the findings back? And Jeff, we can start with you.
Well, actually, I think this was kind of a complete surprise. As Jake alluded to earlier, this issue sort of hadn't been explored in interventional radiology at all. If you look at burnout in general, burnout is thought to be prevalent in only 30% of non-healthcare workers and about 40% of healthcare workers in general. Surgeons report burnout of around 40%. Diagnostic radiologists report rates of burnout of 50 to 60%. But it's actually shocking that the rates of burnout are so high in interventional radiologists. If you just look last year in a national burnout study, some of the highest rates were in the 50s and 60s for neurology and urology. So IR, interventional radiology, with upwards of 70%, is actually one of the highest documented rates of burnout, if not the highest.
I think speaking in those same terms too, in doing our literature review for this paper, I think I encountered only one other medical subspecialty that had a higher rate when we look retrospectively now seeing this rate, and that was among cardiothoracic surgeons. So I think these results definitely speak to underlying factors related to radiology and then specifically interventional radiology too. Because even when previous studies looked at diagnostic radiology, they were ranked among the top 5 of medical specialties in burnout. So I think looking at the factors, in addition to the diagnostic side, that contribute from the interventional side, I think those factors combined are kind of what set ourselves up for having such a high finding in this paper.
Wow. And I noticed from the paper that there was an open-ended question, maybe at the end of the survey. One, I wanted both of you guys to speak to what exactly the question was, and did any themes emerge from the open-ended responses where people were just able to freely type in, like, what affects them for burnout? And Jake, we can start with you.
So the question was worded as an optional question at the end of the survey, and it said, in your own words, the greatest contributor to burnout in your workplace is, and then we left it open at that. And looking at the responses, since it was an open-ended one, it's hard to just put them into discrete categories, but looking at general themes, many of the things people cited were administrative pressures on productivity, relationships between the interventional radiologist and their ancillary staff, kind of workload, work hours, and then issues related to inefficiencies with the electronic medical record, and then some lack of recognition and respect from other medical and surgical subspecialties as well.
Interesting. And Jeff, from your perspective, having been out in practice for a little while, did any of the open-ended responses surprise you, or did they echo maybe some of the sentiments or suspicions that you had before you read them?
I think some of the initial findings, the burnout being present in women maybe, or the specific hour requirements, were a little bit new to me. But the overall feelings that people had about the generalized causes or the unique causes of burnout were not surprising. I think any of us who have been in practice certainly know there at times can be a mismatch between physicians' desires or notions and administrative or bureaucracy, as well as challenges or difficulties with medical records, which sort of at times limits our ability to take care of patients efficiently and adequately. So I'm not surprised at all. I think all of us can appreciate and echo every single one of the responses that the open-ended questions provided.
So in looking at the results, to me, it was no surprise that interventional radiologists who were working greater than 80 hours per week would be showing higher rates of burnout. Was it a surprise to have one of the cohorts as like female interventional radiologists showing higher signs or being at higher risk for burnout? Was that a surprise, or was that something that bore out in other specialties that have been looked at for burnout previously? And Jake, we can start with you.
Looking at other work on burnout, they have found not as high, but higher rates of burnout among female surgical residents and surgical attendings. So it's been a finding that's been at least produced in previous papers looking at this issue. But I think it's something, when we look at interventional radiology as a whole, it's not probably unsurprising when we start looking at some of the factors that may have contributed to this, mainly being the discrepancy in sex within the interventional radiology as a whole. And we look at that gender gap and we think of different stressors that could be placed upon women compared to their male counterparts, including kind of having that work-life balance, having increased rates of work-home conflict, and increased pressures for having to maintain kind of dual roles as a physician and either a mother and a spouse that women kind of take on higher proportions of than their male interventional counterparts.
So taking a left turn a little bit, can we talk about, it's a two-part question. So what are some of the early and late signs that a physician may be showing of burnout? And can physicians recognize when they're showing these signs of burnout? Jeff, can we start with you on this one?
So I think they're the obvious things that we sort of all feel, but may not be the best at recognizing. So it typically burnout is associated with, say, poor work productivity, less than ideal interactions with friends and colleagues. So these are basically a global sadness or emotional exhaustion. And I know we probably all feel these things, but we're somewhat persistent and we don't acknowledge them and we don't really change our practices. But the hard part is that these feelings can eventually lead to sort of early career termination. And actually, they have been shown to be associated with increased suicide as well. So unfortunately, I think we're aware of them, but we're not particularly great at finding a solution to them.
Are there any suggestions for listeners if you think you may be falling into a well of physician burnout? Any things that you can kind of take a good look at, either in your practice or how you're feeling, to have some self-awareness or some recognition that you may be in this spiral of physician burnout? Jake?
I would say first and foremost, if you feel like you are experiencing some of these symptoms, you can always reach out to whatever mental health support you have, either within your system or that you have pre-established, and you can discuss some of these issues with them, and then they can kind of maybe provide further insights into it. Outside of that, there's been lots of interventions that are targeted toward helping people with symptoms of burnout on kind of personal, group level, and then kind of system-wide interventions as well too. Some of the things that we've found in past searches that have helped people with symptoms of burnout is having regular exercise. Working on mindfulness is one of the big individual level kind of things people have promoted as being able to help physicians, just kind of being aware of where your emotions are coming from, where your dissatisfaction with your work is coming from. And I think one of the big things I found when kind of reading through a lot of the literature here, and it kind of speaks to that issue of autonomy when we're looking at system level issues, is that if you as a physician are working on work that you find meaningful 20% of the time, so just a fifth of your work is on something you find meaningful, then they saw burnout rates to be significantly lower among those individuals. So I think just recentering yourself, finding what really got you into medicine, and then reaching out to those resources and mental health that you have around you, I think are good early steps that you can kind of look at and consider when you think you may be suffering from these symptoms.
I was going to say, as Jake alluded to, there's almost a sort of mismatch between some of the maneuvers that had been helped to prevent burnout and a little bit what the survey actually showed. So historically, as Jake alluded to, mindfulness training or group therapy or exercise has been used to help folks with burnout, and it certainly has been shown to help in multiple studies. But the open-ended question in our study here helped identify many other problems, institutional, hospital-based problems that also need to be addressed adequately, or no matter how well the physician attempts to individually improve himself or protect themselves, it's likely going to fail ultimately.
So if I hear you correctly, there are a lot of tactics that are brought up that the individual can take on to maximize their resilience. But in essence, you're describing more of a systemic problem that needs to be addressed on a systemic level if the IR as a profession is going to succeed in reducing rates of physician burnout.
Exactly. I think, for example, exercise therapy certainly helps, but if your hospital is horribly inefficient, you're working much longer hours, your electronic medical record is poorly integrated and is cumbersome, no matter how many, even if you recognize it internally and undergo group therapy or exercise, it's not going to fix the underlying dysfunction or sort of the root of the problem.
The three things that were mentioned in the paper for individuals to do were mindfulness training, small group discussions, exercise. I think most people are familiar with small group discussions and exercise. Can you guys talk a little bit about what exactly is mindfulness training? Jake, we can start with you.
So I think when they talk about mindfulness training, I think a lot of that is related to, it's not all just meditation, but a lot of it is taking time away from your day where you're able to just kind of be alone with your thoughts and look inward upon yourself and look at what's the root of the way you're feeling and what's causing a lot of your emotions that you would either not want to happen or that you think associated with burnout. So it's looking at where those emotions are coming from and trying to think of ways that you can internally kind of recognize that and then in the future kind of curtail those or kind of have a better sense of when you are feeling like that, so then you can decrease yourself feeling like that in the future. And I think it's a lot of it just comes from inwardly looking and having that dedicated time to kind of reflect. Okay.
Jeff, looking to you, I know that you've been a part of a couple different large healthcare systems. Whenever you look at like the larger healthcare systems, is there anything that some of the places that you've been are doing right and doing well, and maybe ideas that other interventional radiologists can take to their healthcare systems to say, hey, this is an example of something that's working well in terms of combating physician burnout, or even on the converse, have you seen some things that aren't going so well and you think maybe are bad examples or bad players in terms of, leading to increased rates of physician burnout?
Well, I certainly know that very large institutions, such as Mass General and some of the Boston programs, Stanford, Mayo Clinic, and other prominent institutions, actually here at the University of Washington as well, there's been a dedicated identification and a appointment of a dedicated health wellness dean or director of global wellness in medicine. So there's been a shift towards promoting ideas of wellness and recognizing burnout in general. So I think that's the very first step, is to identify that it actually is a problem and that steps need to be taken. In a smaller set, in a microcosm, just having good relationships with your colleagues and having open discussions or bi-weekly meetings or bi-monthly meetings, just to discuss the general well-being of you and your colleagues, rather than having work be a factory. These are your friends that you spend the majority of your time with. So becoming closer with them, discussing these issues with them, and knowing that work is, there's much more to work than doing the procedures and the interventions. It's supporting one another and acknowledging one another's needs and ongoing concerns.
Great advice. So both of you guys were authors in this paper, which was the first to take a look at physician burnout, specifically for interventional radiology. Where do you guys see the next step, or what's the next milestone in terms of putting something together for interventional radiology to either take a closer look at this, or what's the next step in taking our practice from the highest rates of physician burnout to something that's, along a more normal level? Jake, we can start with you.
So I think there's kind of two perspectives or two different approaches you could look at going forward. I think the first is having a closer inspection of where this burnout is originating from among the interventional radiologists. When you looked at our survey, we had a disproportionate number of early career interventional radiologists as respondents. And I think that was a lot related to how we disseminated the survey, which was through email and social media. So I think having a better delineation and specifically looking at either trainees, early career physicians, and late career physicians would be important, because I think the factors that contribute to burnout would vary significantly among those different generations. And I think if you're going to start tailoring interventions for interventional radiologists, then I think you have to know what the specific root cause of it is. And then I think on the second front, I think the next avenues of research would be actually instituting some of these specific interventions and then seeing if they are successful among interventional radiologists. So then we can further develop institution-wide kind of initiatives and spread these among interventional radiologists, whether that's through SIR or other resources that we can kind of disseminate it so these practices can be further known and instituted.
So, Jeff, same question to you. Where do you think the next step is as far as research into physician burnout?
Well, I think the first step is sort of this paper was groundbreaking in identifying the two main contributing factors, being that women and work hours were associated with increased burnout. So now we, I think globally on a whole, make some changes here. So I think all of us have been including or involving more women in our various programs, in our specialty, and in our society as a whole. So that is attempting to make an improvement in that regard. And then I think we make steps to limit our work hours in general. And I think, as Jake sort of alluded to, this is sort of the tip of the iceberg, and a much more global understanding of this whole concept needs to be done. This study was in approximately 300 interventional radiologists. But if you just think of those in the U.S., it's more than 7,000. So we need to understand what all our members and all our individuals are feeling. And I think the Society of Interventional Radiology, with some other sponsors, the Mayo Clinic, is conducting a larger burnout assessment to just identify exactly what interventional radiologists are feeling and how to tackle it in the future.
Excellent. So, guys, we covered a lot of material today. Final thoughts? Is there anything any questions I didn't ask or anything that was left unsaid with regards to physician burnout? Starting with you, Jake.
I would say, I think that this is kind of indicative of where medicine is as a whole right now. Whether the numbers vary between specialties, I think is kind of irrelevant in the grand scheme of things. I think we realize there's a lot of system-wide issues, and I think a lot of this is bearing out kind of in the setting of the pandemic right now too. And we're seeing a lot of institution-wide initiatives that have worked well and have had fluidity and been implemented well. And then we've also seen instances where administration has not adapted well and they've been kind of rigid, and it's led to poor responses. So I think just looking at that and how it plays out, I think is a kind of an insight that we can take and apply to burnout when we look at where we can make easy changes and where we can have institutions and the administration look at this issue and make wider kind of sweeping changes that would be able to address some of these big issues outside of just the individual ones too. So I think thinking of it in that context and moving from there, I think is definitely something to consider as a whole.
Excellent. And Jeff, same thing. Final thoughts on physician burnout?
I think the importance here is that this just brings to light some of the exhaustion that we have in our specialty in general, and now complicated by some of the current situation with COVID. It just sort of makes us think that we really need to take time for ourselves, take time for our friends and families, and really focus on yourself and taking care of yourself, because that's important. And that's what will get you through life ultimately.
Excellent. Excellent advice, guys. Good discussion today. Dr. Bundy, Dr. Chick, thank you guys for coming on. Jake, appreciate you coming on for your first time. Jeff, always great having you back.
Yeah, thanks for having us.
Thanks for having us. And congratulations, guys, again, for doing an outstanding job over the past few months. I think you're really disseminating some fantastic information to the listeners of our own specialty and now multiple other specialties as well. So thanks again, and keep up the great work.
All right. Appreciate the endorsement. To the audience, thank you guys for listening. We covered a really important topic today. If you guys enjoyed the podcast but want more, check out the show notes on this episode. I'm usually about a week behind in putting them out, but they will be out, and those will be available for review. And the paper that we discussed today will be included in the show notes. If you guys enjoyed the podcast and want to support the show, here are 2 easy ways. First, take 1 second and press subscribe button on whatever platform you're listening on. This helps platforms like iTunes or Spotify know that you, our audience, value what we're doing and you're interested in getting our latest content as we're producing it. Second, if you're really getting value from these podcasts, please go to iTunes and leave us a short written review. This helps us in a lot of different ways. Plus, we love getting the feedback, good or bad. And for those BackTable listeners that stuck around to the end, we have an added bonus for today's episode. Our extra music comes to you from the one and only Dr. Ari Isaacson out of UNC in Chapel Hill. If you like this music as much as we did, leave him a comment at Twitter. His handle is at Ari Isaacson MD. Guys, enjoy.
Aaron, Chris, and Mike on the back table. The best in podcasts like Larry King is the cable. Legends in the biz like Aesop was the fable. Spewing vascular pearls like only they're able. IRIC, vascular, all in one. Coming together in the lab to get the job done. Minimally invasive, therapeutic and creative. Q2 Meet podcast with contact clearly stated. Worldwide, global reach. They practice what they preach. International guests with wisdom to teach. So subscribe now, you know just what to do, or else you might get Twitter climbed by Dr. Bob Ryu. BackTable, 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 BackTable.